to the overview. So first we say that Calculi or kidney stones are found anywhere along the urinary tract. So most often, the stones are usually found in the renal pelvis or the calyces. They usually vary in size and type and may be single or multiple. Most stones usually are composed of calcium oxalate or phosphate, but patients may have different stones of different composition. We have nephrolithiasis. These are stones specifically found in the kidneys, whereas those stones specifically found in the ureters we are referred to as urolithiasis. The main clinical presentation of the stones is the renal colic. So this pain is caused by the renal calculi. Renal calculi are also referred to as kidney stones or the urolithiasis. We have variation in the renal calculi. So we say renal calculi vary in size and type. Small calculi may remain in the renal pelvis or may pass down the ureter. A staghorn calculus, this is a cast of calicle and pelvic collecting system, may develop from a calculus that stays in the kidney. Okay, we have those multiple small calculus, can be able to see. Then we have the staghorn calculus, the one that has been able to occupy most of the parts of the renal pelvis. You can be able to see in this diagram. Pathophysiology of the stones. We say that the calculi normally form when substances that normally dissolve in urine, such as calcium oxalate, malates, and calcium phosphate, precipitate and form a solid substance. So the renal calculi stones are composed of, number one, and this is good for us to know that they'll form the types of the stones. First one is calcium stones, and these calcium stones they form from calcium oxalate and calcium phosphate or a precipitate. You have the cystine stones. These are caused by autosomal recessive inherited disorder involving an excess of the amino acid cysteine. We have the protein stones. These are caused by pyelonephritis or chronic hemodialysis. We have the struvite stones. They form when ammonium magnesium phosphate is precipitated in females with UTI. Uric acid stones. These are they form when purines are broken down in conditions such as gout or during chemotherapy. We have large, rough calculi may occlude the opening of the uteropelvic junction. And this uteropelvic junction, we looked at it when we were looking at the overview of the urinary system anatomy. If you never looked at it, a link will be popping up and you can be able to review the topic. Followed now next we have the dilatation, the stretching and the spasm from the acute obstruction can lead to colic like pain, which is the main clinical presentation of the stones. So the frequency and the force of peristaltic contraction increase pain, as so do local inflammation, irritation, and edema. Great. So guys, we can be able to see the different types of the stones. We have the kidney stones, majorly made up of calcium. We have around 80%. Okay, risk factors including calcium or vitamin D, dietary supplements, foods very high in oxalates like avocados, grapevine, oranges, spinach, tomato sauce. Okay, you have around 10% forming the struvite stones, composed of magnesium, ammonium, and phosphate. Major risk factors being the UTIs, okay, infections. We have the uric acid stones in about 9%, and major risk factor include diarrhea and gout. Then you have the cystine stones. The cystine stones, these are related to autosomal disorder, a rare disorder called the cystiuria. Okay. Then lastly, we have protein stones. These are caused by pyelonephritis or chronic hemodialysis. I have a quiz here, guys. When providing discharge teaching to a client with uric acid calculi, the nurse will include an instruction to avoid which type of diet? Low calcium, low oxalate, high purine. Guys, uric acid calculus are related to high purine, so it's best to avoid this kind of diet, making D as the correct answer. We have already talked about the risk factors, but it's good to clarify that on the courses we have no definite single factor. So all these conditions will be attributed to the different risk factor, ranging from dehydration, that is low fluid intake. We have UTI, especially the struvite, urine pH changes, urinary tract obstruction and structural changes, immobilization, metabolic factors such as hypercalciuria and decreased magnesium levels, personal or family history where someone may be predisposed by the mere fact that they might have had that infection or the conditions runs in the families. Certain medication, especially the diuretics, calcium-based antacids, tazanavir sulfate, predispose one to these calculus. We have high intake of calcium supplements if not taken with food. Diet high in protein, sodium, saturated and unsaturated fats and sugar, obesity, diabetes or hypertension, maladaptation condition such as after the bariatric surgery or hypervitaminosis D. Okay. Incidence. You find that this condition is more common in males because of the risk activities that men, of course, get involved, especially like taking alcohol, which could be contributing to formation of this calculus. The condition is more common and affects people of ages 20 to 40. Remember, this is when the people are the most active. Okay. The peak is usually at around age 35 and 45. Calcium stones account for approximately 75 to 80% of all stones. Okay. History of a family member with a renal calculi normally doubles the chance of developing the calculus. We are saying that up to 2 million emergency room visits occur annually as a result of kidney stones, especially in developed nations. We have urinary tract obstruction as a complication, upper urinary tract infection, which normally leads to renal parenchyma damage. As a result, you could have kidney cell necrosis, hydronephrosis, ureteral scarring and stenosis, the perforation, the abscess, and the sepsis. Okay, so we can be able to abbreviate these renal stones or complication by having the MOHIM. Okay, so that M stands for migration, leading to pain and obstruction. The obstruction leads to hydroureter and hydronephrosis or calculus anuria, hematuria due to injury of the urinary mucosa. We have infections, especially the cystitis, pyelonephritis or pyroureter or pyelonephrosis. Lastly, we have metaplasia, where the squamous metaplasia mutates to form the squamous cell carcinoma. Great. Quiz. In addition to nausea, severe pain, flank pain, a female client with the renal calculi has pain in the groin and bladder. What additional signs should the nurse assess? Nephritis, referred pain, urine retention, additional stone formation. Very good. Now that you've talked about groin and bladder, yes, referred pain. Very good. So the pain associated with renal colic due to calculi is commonly referred to the groin and the bladder in female clients and to the testicles in male clients. Nausea, vomiting, and abdominal cramping and diarrhea may be present. Nephritis or urine retention is unlikely because of the referred pain. Okay, the type of pain described in these situations is unlikely to be caused by additional stone formation. Okay, and that makes our answer to be referred pain. Okay, let's look at an assessment. Yeah, an assessment, we have history taking and physical findings, that is physical examination. So on history, we have classic renal colic pain. With calculi, the renal pelvis and calyces will have relatively constant dull pain. When there's traveling of the calculi to the ureters, you have pain that moves from the flank to the lowest abdomen and groin, okay, possibly to the scrotum. And that is where we are going to have the referred pain that we've just talked about. We have pain of the fluctuating intensity and may be excruciating at its peak. We have nausea, vomiting, fever, chills, anuria, urine frequency, dysuria, being the painful urination, and difficulty finding a comfortable position. When they are subjected to examination, what are the physical findings? We have hematuria, abdominal distension, costovertebral tenderness and palpation, tachycardia, and elevated blood pressure. So the question says that a client presents to the emergency department complaining of a dull, constant ache along the right costovertebral ankle, along with nausea and vomiting. The most likely cause of these client symptoms is renal calculi, overdistended abdomen, interstitial cystitis, acute prostatitis. Great, guys, we agree that we are dealing with renal calculus, and that is the major cause of the symptoms that have been described above. So what are the diagnostic tests for kidney stones? Okay, we have number one, laboratory. Number two, we have the imaging. So on number one, we say we have a 24-hour urine collection that shows calcium oxalate, phosphorus, and uric acid excretion levels. Urinalysis shows increased urine specific gravity, okay? And in that case, we need more rehydration. Urine pH of less than 5.5 suggests uric acid stones. pH of greater than 7 will suggest struvite. Okay, and remember, struvite stones will always be associated with UTI in females. We have urine culture and sensitivity, which determines the concomitant urinary infection. White blood cells and differential may be slightly increased. Then you have the creatinine level may be obtained to evaluate kidney function. On the imaging, we have the Coob or non-contrast CT scan. This one normally reveals the size, shape, location of most renal calculus. We have excretory urography. This one helps confirm the diagnosis and determines calculi size and location. We have intravenous pyelogram, computed topography scanning of the abdomen and pelvis, or MRI. This one may reveal stones or obstruction of the ureter. We have retrograde uteropelography. This one may determine uteral calculus. Then you have ultrasonography of the kidney and perirenal structures, can determine hydronephrosis, ureteral dilatation, obstructive changes, and radiolucent calculi that are usually not visible or seen on the Coob's radiology. On treatments, The first type of treatment, we are talking about the general, and the general, we are saying that we need vigorous hydration of more than 3 liters per day, unless if hydronephrosis is present or increased fluids are contraindicated because of comorbid condition. Number 2, we have straining of urine for the stones. What about diet? In kidney stones, we need restrictions based on stone composition. For example, restriction of high oxalate foods such as the spinach, chocolate. In the case of calcium oxalate stones, avoidance of excess proteins, saturated, unsaturated fats, and solid intake. We need adequate potassium intake. We need juices high in citrate for hypocitraturias. Then you have increased daily intake of non-sugar sweetened beverages to increase urine volume, unless it is contraindicated. What about activity? We're saying that ambulation is tolerated. Medication for Calculi. We are saying that we need to have IV fluid administration. We need analgesics such as a combination of NSAIDs such as oral, nasal, or injectable. Ibuprofen, codeine, phosphate acetaminophen, morphine sulfate are all included. Antibiotics, that's number 3, for infection based on the culture and sensitivity test conducted. We also need to use because of the nausea and vomiting, we have the use of antiemetics, especially the ondansetron hydrochloride. Especially for uric acid stones, we will have the use of allopurinol or potassium citrate to dissolve the uric acid stones. We have potassium citrate or chelating agents such as captopril, for cystine stones, dissolutions and prevention. We have the use of the thiazide diuretics such as hydrochlorothiazide when you have hypercalciuria, Potassium citrate is used when you have hypocitraturia. You have oral calcium or magnesium, cholestyramine, and potassium citrate to treat enderic hyperoxaluria, We have prednisone used to reduce uterine inflammation. We have nifedipine or alpha blockers, to promote uterine stone passage. From treatment, we go to surgery, and we are saying that we have various surgical intervention for patients with stones, Number 1, we have extracorporeal shockwave lithotripsy, especially for stones in the renal pelvis and upper ureter, And this is how we normally position our patient. You can see? Yes. So you're saying that in extracorporeal shockwave lithotripsy, the patient is positioned on a fluid-filled cushion through which the shock waves are sent directly to the stones, So the patient receives anesthesia to ensure absolute stillness during the procedure. We also have others, apart from extracorporeal shockwave lithotripsy. We also have uteral stents. We also have uteroscopy. We have percutaneous nephrolithotomy. This one is done typically for struvite stones. What are the nursing considerations? Starting with the nursing intervention, I say that you need to provide IV fluids as ordered and maintain IV patency. Inspect the IV sites for signs of inflammation or infection. Encourage fluid as needed, and encourage the patient to ingest 2 to 3 liters of fluid per day. That is our number 1. Number 2, we need to strain all urine and send solid material for analysis in order to get the composition. You need to encourage ambulation to aid spontaneous and calculus passage. We need to screen for and assess for patients' pain using facility-defined criteria that are consistent with the patient's age, condition, and ability to understand. We need to treat the patient's pain as needed and ordered using non-pharmacological such as positioning, applying heat, pharmacologic, or a combination of both approaches. We need to monitor closely if the patient is at high risk of adverse outcomes related to opioid treatment if prescribed. We need to reassess and respond to patient's pain by evaluating the response to treatment and progress towards pain management goals. We need to inspect urine for color. We need to know the amount, clarity, and evidence of bleeding, if any. We need to obtain specimen for laboratory testing, such as follow-up urinalysis, serum calcium, and uric acid levels as indicated. We need to prepare the patient and family for surgery as indicated, provide pre-operative and post-operative education. We need to evaluate for risk factors for stone formation and provide information on decreasing modifiable risk factors. What about monitoring? We need to monitor the pain level and effectiveness of intervention using the OPQRST mnemonic. We need to monitor intake and output. Yes, at least a patient should be having 30 meals per hour, okay, as the output recommended, okay. For the pain scale, we are going to use the scale so that we are going to intervene based on the value and how the patient is able to describe pain. We need to monitor for urine elimination, including evidence of stones, okay. Sorry. We need to look at the signs and symptoms of the infection and signs and symptoms of urine obstruction. On nursing procedures, we need to have a clean catch-up, that is a midstream urine specimens, okay? We also need to have informed consent. Remember, it's the role of the surgeon to ensure that they have taken the informed consent from the patient. We need to have the intake input measurements, IV bolus injection, IV catheter insertion, IV catheter removal, IV pump use, IV secondary line drug infusion, nutritional screening, oral drug administration, pain assessment that we have already talked about. You assess, you manage, postoperative care, preoperative care, safe medication administration practices, and general. Then you have the straining of the urine for Calculi, yes, and then your stained insertion and assisting, okay. Great, guys. About patient teaching, we are saying that generally you include the patient family and caregiver in the teaching when appropriate, okay. You provide information according to the individual's communication and learning needs. You need to be sure that you have covered the following. You discover the disorder, the diagnostic tests, treatment, including type of stones and measurement to reduce the reoccurrence. Okay? We need to talk about the prescribed drug therapy, such as analgesics, including the drug name, dosage, frequency of the administration, expected results, duration of the therapy, and possible adverse effects. We need to talk about the pain management plan and potential adverse effects of pain management treatment. We need to talk about the safe use, storage, and disposal of opioids if prescribed. Nurses need also to talk about the passage of stones depend on the location size, and 75% of patients pass the stones spontaneously. We need to talk about the modifiable and non-modifiable risk factors. Okay? We need to talk about the prescribed diet and the importance of adherence, including foods to avoid based on the type of stones, the composition of the stone. Okay? We need to talk about the intake of non-sugar sweetened beverages. of about 2 to 3, that is majorly water per day, so that urine is clear rather than yellow. We need to talk about how to strain urine for stones, including using a coffee filter for straining at home. We need to talk about the signs and symptoms that need to be reported immediately, such as sudden recurrence and increase in pain, fever, vomiting, or hematuria. We need to adhere to the follow-up care, including services such as laboratory testing, acid analysis to evaluate the passage of the stones. What about the discharge plan? Make sure that you participate as part of the multidisciplinary team to coordinate the discharge planning efforts. The team should include the bedside nurse, the case manager, nutritionist, physical therapist, urologist, and the physician. We need to assess the patient's and the family understanding of the diagnosis, treatment, follow-up, and warning signs, which is to seek medical attention. Also assess the patient's level of independence before admission. Identify the patient's formal and informal supports. Identify the patient's and family's goals, preferences, comprehensions, concerns about discharge. You need to confirm arrangement for transportation to initial follow-up. You need to provide a list of prescribed drugs, including the dosage, prescribed time schedules, and adverse reaction should be reported to the physician. We need to provide the patient, family, or caregiver as needed with written information on medication that the patient should take after the discharge. We also need to assess the patient's and family understanding of prescribed medication, including dosages, administration, expected results, duration, and possible adverse effects so that they can easily cooperate and get better outcomes. We need to assess the patient on the ability to obtain medication, identify the party responsible for obtaining the medication, of course. If patient has challenges, you need to connect them to the medical social worker. Instruct the patient to provide a list of medication to the physician who will be caring for the patient after the discharge, and then to update information with the physician and continue medication. Changes in dosages or addition of new drugs needs to be reported to the physician. Ensure that the patient and caregivers receive medical contact information. Ensure that the patient or caregiver receives a copy of discharge instruction and that a copy is placed in the patient medical record and can be retrieved easily upon the patient seeking care. Assess the patient's and family understanding of teaching by using a teach back, where possible. You document the discharge planning, evaluating the patient's clinical record, including who was involved in the discharge planning teaching, the understanding of teaching provided, and any need for follow-up. What are some of the commonest nursing diagnoses for patients with kidney stones or nephrolithiasis or urolithiasis? We are saying you have acute pain, of which the goal should be the patient will be able to identify factors and the factors that relieve pain. The patient will be able to verbalize or demonstrate relief from pain. Here are some of the interventions that will be able to help us achieve the goal. Okay? The other goal is about impaired comfort. And in impaired comfort, we are saying that our goal is that the patient will notify the physician about the discomfort before it becomes unmanageable or unbearable. Another one is that on the same diagnosis, that the patient will verbalize or demonstrate feelings of comfort. Okay, here are some of the interventions that will be able to help us achieve that objective. The other serious nursing diagnosis is ineffective renal perfusion, and this one is a risk, infective renal perfusion. So what are the goals in this case? The patient will maintain signs of adequate renal perfusion, or the patient will verbalize understanding of the signs and symptoms of ineffective renal perfusion. So ladies, here are some of the interventions that we are supposed to carry, starting from assessing patient for the edema, assessing for uremic findings, and assessing for patient capillary fill, mucous membranes, Steenberger as indicated. Okay. The next goal for the nursing diagnosis for patients with nephrolithiasis or stones, they're saying it's an infection risk. And they're saying that the goal is that the patient will remain afebrile, the patient will have no sign of erythema or purulent discharge, the patient will achieve timely wound healing, the patient will verbalize understanding of signs and symptoms of an infection. Okay, here are some of the interventions that we need. We also have the knowledge deficiency as one of the nursing diagnoses. And the goal in this case will be the patient will demonstrate knowledge retention related to renal calculi, and the patient will demonstrate behaviors congruent with expressed knowledge. Okay? Another problem for the patient with a kidney stone is nausea, and you're saying that the goal is that the patient will report a decrease in or absence of nausea. Okay, and that was some of the intervention for that case. So guys, here is a quiz for you. A client returns from extracorporeal shockwave lithotropsy with ecchymosis over the left flank area. Vital signs are within normal limits, and the client appears to be in no acute distress. Which nursing intervention is appropriate? Apply a cold compress to the site, notify the physician immediately, place the client in the left lateral position, maintain NPO status in anticipation of a surgical intervention. Okay guys, you can see the vitals are within normal findings and the client appears to be in no distress. So there is no need for maintaining NPO, okay, and notifying the physician immediately. Okay, we should only be concentrating on applying a cold compression to the site and placing the client on the left lateral position. So which one among these A and C answers our question? And you know our concern is the client has ecchymosis over the left flank. Okay? Yes. So when you place the patient on the flat, you are going to increase pressure on the other side. So if it was bleeding, it will exacerbate. Okay, placing or applying a cold compress to that side becomes a better alternative. Okay, so ecchymosis is anticipated following extracorporeal shockwave lithotropsy. Applying a cold compress to the site may help minimize bruising caused by the procedure. This is not a situation requiring the physician to be notified, as it is expected finding. Okay, the patient does not have to remain NPO. Placing the patient on there may increase the pain. Okay, what about this one, guys? And this one is the last one, guys. Which finding in the client's history will be the least likely to have predisposed the client to a renal calculi? A, having several urinary tract infection in the past 2 years. What did you say about this type of stone here will be? Struvite Stones, very good. Having large dosage of vitamin C over the past several years. Okay? Yes. Calcium, yes. Calcium stones, yeah. Drinking less than the recommended amount of milk. We can keep this one for consideration. Having been on prolonged bed rest after this, yes, this one also leads to a stone, okay? Guys, the correct answer in this case will be drinking less than the recommended amount of milk, okay? A high rather than low milk intake predisposes one to renal calculi formation, okay? Owing to the calcium in the milk. So recurrent urinary tract infection are implicated in stone formation as certain bacteria promote stone formation. High doses of vitamin C are risk factor because they can increase the citric acid level. Okay, prolonged immobility is a risk factor for renal calculi because it causes calcium to be released into the bloodstream. Okay, so those are some of the ways in which we can look at the kidney stones. Okay, remember, thank you so guys for this presentation. Remember to like the video and subscribe in order to get channels and videos related to this. Thank you so much. Have a nice time.